Hello everybody. Today we are going to discuss about the Surviving Sepsis Campaign Guideline 2021. So the screening and early treatment. Screening for the patient with sepsis and septic shock. So the guidelines recommended using performance improvement program for sepsis, including sepsis screening for acutely ill, high risk patient and standard operating procedure for treatment. And it has very strong recommendation. Now, the guidelines recommended using QSOFA compares to SIRS, NEWS, and MUSE as a single screening tool for sepsis or septic shock. It has a very strong recommendation, and they have also suggested using measuring blood lactate level. And the recommendation for this statement is very weak. Now, regarding initial resuscitation, sepsis and septic shock are the medical emergencies. And guidelines recommended that treatment and resuscitation should begin immediately. It has the best practice statement. For patients with the sepsis-induced hypoperfusion or septic shock, guidelines suggested that at least 30 ml per kg of IV crystalloid fluid should be given within the first 3 hours of the resuscitation. For adults with the sepsis and septic shock, we suggest using dynamic measures to guide fluid resuscitation over physical examination or static parameter alone. The dynamic parameter including response to the passive leg raise or the fluid bolus using stroke volume or the stroke volume variation, pulse pressure variation or echocardiography were available. For adults with the sepsis or septic shock, the suggestions are guiding resuscitation to decrease the serum lactate in patient with the elevated lactate level over not using serum lactate. It has very weak recommendation. During acute resuscitation, serum lactate level should be interpreted considering the clinical context and the other cause of elevated lactate. For adults with the septic shock, we suggest the using capillary refill time to guide resuscitation as an adjunct to other measures of perfusion. Now, regarding mean arterial pressure for adults with the septic shock on vasopressors, the recommendations are the initial target mean arterial pressure of 65 mmHg or over higher mapped artery. Now, for adults with the sepsis and septic shock who require ICU admission, we suggest admitting patient to the ICU within 6 hours. Now, regarding the diagnosis of infection, for adults with the suspected sepsis and septic shock but confirmed infection, we recommended continuously reevaluating and searching for alternative diagnosis and discontinuing empirical antimicrobials if an alternate cause of illness is demonstrated or strongly suspected. Now, the time to antibiotics. For adults with the possible septic shock or high likelihood of sepsis, we recommended administering antimicrobial immediately, ideally within 1 hour of recognition. It has very strong recommendation and low quality of evidence. Uh, for adults with the possible sepsis without shock, we recommended rapid assessment of likelihood of infection versus non-infectious causes for acute illness. Now, the remarks are rapid assessment include history, clinical examination, test for both infection and the non-infectious causes of acute illness, and immediate treatment for the acute condition that can mimic sepsis. Whenever possible, this should be the completed within 3 hours of the presentation so that decision can be made as to likelihood of infectious cause of the patient's presentation and timely antimicrobial therapy provided if the likelihood of sepsis is thought to be high. For adults with possible sepsis without shock, we suggest the time-limited course of rapid investigation, and if concern for infection persists, the administration of antimicrobials within 3 hours from the time when sepsis was first recognized. Again, it has got very weak recommendation. For adults with a low likelihood of infection and without shock, we suggest deferring antimicrobial while continuing to closely monitor the patient. Now, about the biomarkers to start antibiotic for adult with the suspected sepsis septic shock, we suggest against the using procalcitonin plus clinical evaluation to decide when to start antibiotic as compared to clinical evaluation alone. Again, it has very weak recommendation. And regarding antimicrobial choice, for patient with the sepsis septic shock at high risk of MRSA, we recommended using empirical antimicrobial with MRSA coverage using antimicrobial without MRSA coverage. For adult with the sepsis septic shock at low risk of MRSA, we suggest against using empirical antimicrobial with MRSA coverage as compared with using antimicrobial without MRSA coverage. Now, for adults with the sepsis or septic shock and high risk of MDR organism, we suggest using two antimicrobial with gram-negative coverage for empirical treatment over one gram-negative agent. This treatment has got very weak recommendation. For adult with the sepsis, septic shock, and low risk of MDR organism, we suggest against using 2 gram negative agent for empiric treatment as compared to 1 gram negative agent. For adults with the sepsis or septic shock, we suggest against using double gram negative coverage once causative pathogen and the susceptibility are known. And regarding antifungal agents, for adults with the sepsis septic shock at high risk of fungal infection, we suggest using empiric antifungal therapy over no antifungal therapy. Again, it has got very weak recommendation. For adults with the sepsis septic shock at low risk of fungal infection, we suggest against empirical use of the antifungal therapy. Now, regarding antiviral therapy, we make no recommendation of the use of antiviral agent. Now, about the delivery of antibiotic for adults with the sepsis septic shock, we suggest using prolonged infusion of beta lactam for maintenance over conventional bolus infusion. Now, regarding pharmacokinetics and pharmacodynamics, for adults with the sepsis septic shock, we recommended optimizing dose strategy of antimicrobial based on the accepted pharmacokinetic and the pharmacodynamic principle and specific drug properties. Now, regarding source control, for adults with the sepsis and septic shock, we recommended rapidly identifying, excluding a specific anatomical diagnosis of infection that requires emergent source control and implementing any required source control intervention as soon as medically and logistically practical. Now, the recommendations for adult and septic shock, we recommended prompt removal of intravascular access device that are possible source of sepsis septic shock after other vascular access has been established, and it is included under the best practice statement. Regarding de-escalation of antibiotic for adult with septic shock, we suggest daily assessment for de-escalation of antimicrobial over using fixed duration of therapy without daily assessment of the de-escalation. And it has very weak recommendation and the very low quality of the evidence. Duration of antibiotic for adult with the initial diagnosis of sepsis septic shock and adequate source control, we suggest using shorter over longer duration of the antimicrobial therapy. Biomarkers to discontinue antibiotic. For adults with the initial diagnosis of sepsis and septic shock, adequate source control where optimal duration of therapy is unclear. We suggest using PCT and clinical evaluation to decide when to discontinue antimicrobial over clinical evaluation alone. Now, the hemodynamic management. Regarding fluid management, for adult with the sepsis septic shock, we recommended using the crystalloid as first line for resuscitation. It has a very strong statement. For adult with the sepsis septic shock, we suggest using balanced crystalloid instead of the normal saline for resuscitation. It has got weak recommendations. And for adult with the sepsis septic shock, we suggest using albumin in patient who receive large volume of the crystalloid over crystalloid alone. Again, it has a weak recommendation and the moderate quality evidence. For adults with a sepsis septic shock, we recommended against using starches for resuscitation. It has got strong recommendation. And for adult with the sepsis septic shock, we suggest against using gelatin. Again, it has weak recommendations. Now, the examples of the risk factor for fungal infection, risk factor for Candida species, Candida colonization at multiple sites, surrogate markers such as serum beta-D-glucan assay, neutropenia, immunosuppression, severity of illness like high Apache score, longer ICU length of stay, central venous catheter and the other intravascular devices, person who inject drugs, total parenteral nutrition, broad spectrum antibiotic, gastrointestinal tract perforation and anastomotic leak, emergency gastrointestinal and hepatobiliary surgery, acute renal failure and hemodialysis, severe thermal injury and prior surgery, risk factor for endemic yeast like Cryptococcus, Histoplasma, Blastocystis, blastomyces and the coccidiomycosis. Antigen markers such as cryptococcal histoplasma and blastomyces assay, HIV infection, solid organ transplantation, high dose corticosteroid therapy, hematopoietic stem cell transplantation, certain biologic response modifiers, and diabetes mellitus. Now, the risk factors for the invasive mold infection like neutropenia, surrogate markers like serum and bronchoalveolar lavage, galactomannan assay, hematopoietic stem cell transplantation, solid organ transplantation, high dose corticosteroid therapy, and certain biologic response modifiers. Now, regarding vasoactive agent, for adult with the septic shock, we recommended using norepinephrine as a first line agent or the other over other vasopressors. Uh, Dopamine has a high quality evidence, vasopressin moderate quality evidence, then epinephrine low quality evidence, serlipressin low quality evidence, angiotensin 2 very low quality evidence. In setting where norepinephrine is not available, epinephrine or dopamine can be used as alternative, but we encourage effort to improve availability of the norepinephrine. Special attention should be given to patient at risk of arrhythmias when using dopamine and epinephrine. For adults with the septic shock or norepinephrine with inadequate MAP level, we suggest adding vasopressin instead of de-escalating the dose of norepinephrine. In our practice, vasopressin is generally started when dose of norepinephrine is in the range of 0.25 to zero point 0.5 microgram per kg per minute. For adults with a septic shock, the inadequate MAP level, despite norepinephrine and vasopressin, we suggest adding epinephrine, but it has a weak recommendation. For adults with a septic shock, we suggest against using terlipressin, and again it has a weak recommendation. For adults with the septic shock and cardiac dysfunction with persistent hypoperfusion, despite adequate volume resuscitation and arterial blood pressure, suggest either adding dobutamine to norepinephrine or using norepinephrine or using epinephrine alone. But it has a weak recommendation. For adult with the septic shock and cardiac dysfunction with persistent hypoperfusion, despite adequate balance in arterial blood pressure, we suggest against using levosimendan. Now, vasoactive agent management. No doubt we should, norepinephrine is the first line vasopressor. It has very strong recommendation. If central line is not yet available, then consider initiating vasopressor peripherally. And for septic and septic shock, so target map should be 65 mmHg and consider invasive monitoring of the arterial blood pressure. Now, if MAP is inadequate despite low to moderate dose of norepinephrine, then we need to add vasopressin. If there is a cardiac dysfunction with persistent hypoperfusion is present despite adequate volume status and blood pressure, then consider adding dobutamine and switch to the epinephrine. Now, inotropes. For adults with the septic shock and the cardiac dysfunction with the persistent hypoperfusion, despite adequate volume status and the arterial blood pressure, we suggest either adding dobutamine to norepinephrine or using epinephrine. It has a weak recommendation. For adults with the septic shock and cardiac dysfunction with persistent hypoperfusion, despite adequate volume status and arterial blood pressure, then we suggest against using levosimendan. Then monitoring and the intravenous access. For adults with the septic shock, we suggest using invasive monitoring of the arterial blood pressure over non-invasive monitoring as soon as practical or if resources are available. This treatment has got weak recommendation. For adult with the septic shock, we suggest starting vasopressor peripherally to restore MAP rather than delaying initiation until central venous access is secure. Again, it has got weak recommendation. When using vasopressor peripherally, they should be administered only for short period of time and in vein in or proximal to the antecubital fossa. Regarding fluid balance, there is insufficient evidence to make recommendation on the use of restrictive versus liberal fluid strategy in the first 24 hours of the resuscitation in patient with the sepsis septic shock who still have the signs of hypoperfusion and volume depletion after initial resuscitation. Fluid resuscitation should be given only if patient present with the signs of hypoperfusion. Regarding ventilation, there is insufficient evidence to make recommendation on the use of conservative oxygen target in adult with the sepsis-induced hypoxic respiratory failure. Now, regarding protective ventilation in ARDS, for adult with the sepsis-induced ARDS, we recommended using the low tidal volume ventilation strategy, that is 6 ml per kg over high tidal volume strategy, that is more than 10 ml per kg. And this statement has a strong recommendation. For adult with the sepsis-induced severe ARDS, we recommended using upper limit goal for the plateau pressure of 30 centimeter of water over higher plateau pressure. Again, it has got very strong recommendations. For adult with the moderate to severe sepsis-induced ARDS, we suggest using higher PEEP over lower PEEP, and it has got weak recommendation. Regarding low tidal volume in non-ARDS respiratory failure, for adult patient with sepsis-induced respiratory failure without ARDS, we suggest using low tidal volume as compared to high tidal volume, and this has very weak recommendation. Now, regarding recruitment maneuver, for adult with the sepsis-induced moderate to severe ARDS, we suggest using traditional recruitment maneuver. It has very weak recommendation. When using recruitment maneuver, we recommended against using incremental PEEP titration strategy, and it has a strong recommendation. Regarding prone ventilation, for adults with the sepsis-induced moderate to severe ARDS, we recommended using prone ventilation for more than 12 hours, and it has very strong recommendations. For adults with the sepsis-induced moderate to severe ARDS, we suggest using intermittent neuromuscular blocking bolus over neuromuscular blocking agent continuous infusion, and it has weak recommendation. Regarding ECMO, for adult with the sepsis-induced severe ARDS, we suggest using venovenous ECMO when conventional mechanical ventilation fail in experienced center with infrastructure in place to support in use, and it has weak recommendation. Now, regarding additional therapy, for adults with the septic shock and ongoing requirement for vasopressor, we suggest using IV corticosteroid. It has weak recommendation. The typical corticosteroid used in adult with the septic shock is IV hydrocortisone at dose of 200 mg per day as 50 mg IV every 6 hours or continuous infusion. It is suggested that this is commenced at a dose of norepinephrine or epinephrine more than 0.25 microgram per kg per minute at least 4 hours after initiation. Now, about the blood purification technique for adults with the sepsis and septic shock, we suggest against the polymyxin B hemoperfusion. There is weak recommendation. There is insufficient evidence to make recommendation on either blood purification techniques. Now, regarding RBC transfusion target for adult with the sepsis septic shock, guidelines recommended restrictive over transfusion strategy, and it has very strong recommendation. Restrictive transfusion strategy typically involves hemoglobin concentration transfusion trigger of 7. However, RBC transfusion should not be guided by hemoglobin concentration alone. Assessment of the patient overall clinical status and consideration of extenuating circumstances such as acute myocardial ischemia, severe hypoxemia, or acute hemorrhage is required. Now, regarding immunoglobulin for adult with the sepsis septic shock, we suggest against using intravenous immunoglobulin. It has weak recommendation. Regarding stress ulcer prophylaxis for adult with sepsis septic shock who have high risk of GI bleeding, we suggest using stress ulcer prophylaxis. Again, it has got weak recommendation. Now, regarding venous thromboembolism prophylaxis for adult with the sepsis septic shock, we recommended using pharmacological VT prophylaxis unless contraindicated. For adults with the sepsis septic shock, we recommended using low molecular weight heparin or unfractionated weight heparin for VT prophylaxis, and it has got strong recommendation. For adult with the sepsis septic shock, we suggest using mechanical VT prophylaxis in addition to the pharmacological prophylaxis over pharmacological prophylaxis alone. Okay. Now, regarding renal replacement therapy, In adult with the sepsis, septic shock, and AKI who require renal replacement therapy, we suggest using either continuous or intermittent renal replacement therapy. It has very weak recommendation. In adult with the sepsis, septic shock, and AKI, no eye definitive indication for renal replacement therapy, and we suggest against using renal replacement therapy. For adult with the septic shock, we recommended initiating insulin therapy at a glucose level of more than or equal to 180. It has very strong recommendation. Following initiation of insulin infusion, typical blood glucose target should be 144 to 180. Regarding vitamin C, for adult with the sepsis septic shock, we suggest against using IV vitamin C. Now, regarding bicarbonate therapy, for adult with a septic shock and hypoperfusion-induced lactic acidemia, we suggest against using sodium bicarbonate therapy to improve hemodynamics or to reduce vasopressor requirement. And it has got weak recommendation. For adult with the septic shock, severe acidemia, and AKI, we suggest using sodium bicarbonate therapy. Now, regarding nutrition, for adult patient with septic shock who cannot feed enterally, we suggest early initiation of the enteral nutrition. Now, regarding goals of therapy, for adults with the septic shock, we recommended discussing goal of care and prognosis with patient and family over no such a discussion. Uh, this is a best practice statement. For adult with sepsis or septic shock, we suggest addressing goal of care early, that is within 72 hours or late. That is has got weak recommendation. There is insufficient evidences to make recommendation for specific standardized criteria to trigger goal of care of discussion. Now, regarding palliative care, for adults with septic and septic shock, we recommended integrating principles of palliative care, which may include palliative care consultation based on clinical judgment into treatment plan when appropriate to address patient and family symptom and suffering. For adults with the septic shock, we suggest against routine formal palliative care consultation for all patients or palliative care consultation based on clinical judgment. Now, these are the changes in 2016 changes in 2021 guidelines from 2016 guideline. So in 2021 guideline, we have recommended that the performance of improvement program for sepsis, including sepsis screening for acutely ill, high risk patient and standard operating procedure for treatment. It has got moderate evidence, and in 2016, it has got very low evidence for for improvement program for sepsis, including sepsis screening for acutely ill and high risk patient. So, in 2021, for patient with the sepsis-induced hypoperfusion septic shock, the guidelines suggest that at least 30 ml per kg of intravenous crystalloid fluid should be given within the 3 hours. So, but in 2016, they only recommend to that the initial resuscitation from sepsis-induced hypoperfusion for at least 30 ml per kg of intravenous crystalloid fluid to be given within first 3 hours. Now, in 2021, for adults with the possible septic shock and high likelihood of sepsis, we recommended the administering antimicrobial immediately, ideally within first hour of recommendation. It has got low evidence in septic shock and very low evidence in sepsis without shock. And but in 2016, they have recommended that intravenous antimicrobial should be initiated as soon as possible, whether septic shock is there or not. But that antimicrobial should be administered within the 1 hour. So in 2016, regarding the intravenous antimicrobials, which should be initiated as soon as possible after recognition and within 1 hour for both septic shock and sepsis without shock. But in 2021 guidelines for adults with possible sepsis without shock, where the guideline recommended time-limited course of rapid investigation, and if concern for infection persists, then add the administration of antimicrobial within 3 hours from the time when sepsis was first recognized. And it has very low evidence. And in 2016 guideline regarding Same thing regarding the administration of intravenous antimicrobial, it should be within 1 hour with sepsis or without sepsis. But in 2021 guideline, it has very low recommendation, and they have only suggest deferring antimicrobial while continuing uh, closely monitor the patient if the patient is not in septic shock and there is low likelihood of sepsis. Again, in 2016, they have recommended empirical broad spectrum therapy with one or two antimicrobial for patient present with sepsis septic shock to cover all likely pathogens. For adult with sepsis septic shock at high risk of MRSA, we recommended using empirical antimicrobial with MRSA coverage over using antimicrobial without MRSA coverage. And it is a best practice statement. Now, in 2016, they have recommended empirical broad spectrum with one or more antimicrobial for patient presenting with sepsis or septic shock to cover all likely pathogen, including bacteria, potential fungal and viral coverage. In 2021, for adults with sepsis or septic shock at low risk of MRSA, they suggest against using empirical antimicrobial with MRSA coverage as compared using antimicrobial without MRSA coverage. In 2016, the practice guideline was to recommended empirical broad spectrum therapy with one or more antimicrobial for patient presenting with sepsis septic shock to cover all likely pathogen, including bacteria, potential fungal and viral coverage. For adult with sepsis septic shock at high risk of fungal infection, we suggest using empirical antifungal therapy over no antifungal therapy. That was the statement which was made in 2021 guidelines, but it has low recommendation. In 2016 statement, they recommended empirical broad spectrum therapy with one or two more antimicrobial for patient presenting with the sepsis septic shock to cover all likely pathogens, including bacterial, potential fungal or viral coverage. But in 2021, for adults with sepsis septic shock at low risk of fungal infection, we suggest against empirical use of antifungal therapy. In 2016 guideline, they suggest using either balanced crystalloid or saline for fluid resuscitation of patient with sepsis or septic shock. But in 2021 guideline for adult with sepsis septic shock, they have suggested using balanced crystalloid instead of normal saline for resuscitation. So in 2016, they have suggested crystalloid over gelatin when resuscitating patient with sepsis or septic shock. But in 2021 guideline, adult with sepsis septic shock, we suggest against using gelatin for resuscitation. In 2016 guideline, we suggest they have suggested using either balanced crystalloid or saline for fluid resuscitation of patient with septic shock. And we suggest crystalloid over gelatin when resuscitating patient with septic or septic shock. But in 2021 guideline, there is insufficient evidence to make recommendation on the use of restrictive versus uh, liberal fluid strategies in first 24 hours of resuscitation in patient with septic shock who still have signs of hypoperfusion, volume depletion after initial resuscitation. In 2026, in 2016 guideline, uh, there was a suggestion against using intravenous hydrocortisone to treat septic shock if adequate fluid resuscitation and vasopressor therapy are able to restore hemodynamic stability. If this is not achieved, then they have suggested intravenous hydrocortisone at a dose of 200 mg per day. But in 2021 guideline for adults with the septic shock and ongoing requirement of vasopressor therapy, they have suggested using IV hydrocortisone. In 2016 guidelines, so there were no recommendation regarding use of blood purification technique. And in 2021 guideline also, we suggest against using polymyxin B hemoperfusion. Thank you, friends.